بسم الله الرحمن الرحيم. Welcome to ERA. I'm Dr. Muhammad Talat, Assistant Professor of Radiology, Cairo University. Let us continue our course. We have here CT brain for an elderly patient. As we see here, we have an irregular shape, acute hematoma, located at the left cerebellar hemisphere. As usual, we should identify the location and measure the dimensions, the axial dimensions and craniocaudal dimensions, and the volume as well, as we did in the previous cases. But the teaching points here is the hematoma located at the left cerebellar hemisphere. And once we have any masses or any space occupying lesion or any hematoma, any collections, it's very critical to identify the lesion in the posterior fossa. Why? Because the posterior fossa is a small closed space. So any masses in the posterior fossa can lead to a significant effect. You can see here this hematoma exerts mass effect in the form of compression of the fourth ventricle and mild midline shift to the right side. We can measure the midline shift in the posterior fossa from the center of the fourth ventricle towards the midline, from here to here. It measures about 3.4 millimeters in this case. So how to measure the midline shift? If we are measuring the midline shift in the supratentorial compartment, we should measure the midline shift from the foramen row towards the midline. While in the posterior fossa, we should measure the midline shift from the fourth ventricle towards the midline. The second teaching point here in this case, the hematoma is compressing the fourth ventricle, and once we have any compression upon the fourth ventricle, we should search for any supratentorial hydrocephalic changes. Here, the third ventricle is mildly dilated. The lateral ventricles also are mildly dilated. We should ask ourselves, is this ventricular dilatation considered as a part from the involution brain changes, or is it a true hydrocephalic change? How can we differentiate? We should go ahead for the temporal horns. Look for the temporal horns. The temporal horns are not significantly dilated. Look for this one. Even the temporal horn are preserving their normal configurations. If we have any hydrocephalic changes, the hydrocephalus starts as a temporal horn, so we don't have any significant temporal horn dilatation. So the ventricular dilatation, this mild ventricular dilatation, most properly secondary to the involution brain changes. Also, if we have any old studies, we should compare to the previous studies, may be helpful to detect early hydrocephalic changes. We have also here these areas, white matter, hypodense patch areas, looks like butterfly areas, and this one represents chronic diffuse small vessel ischemic changes. Our third teaching point here in this case is that the cerebellar hematoma is considered one of the common characteristic sites for hypertensive hemorrhage. So we have here 3 sites for the hypertensive hemorrhage. First, basic ganglia. Second, brainstem. Also, cerebellar hemisphere. And also the thalami. Those are the most specific locations for the hypertensive hemorrhage. Basic ganglia and the brainstem are more common than the others. Those are the 3 teaching points in this case. Let us move to our second case today. Elderly patient. We have small hematoma at the left thalamus. We should measure the hematoma, and we should also comment on its mass effect. I think it doesn't exert significant mass effect. And also we have small hypodense area of near CSF-like density, and this one represents area of encephalomalacia. We have also diffuse ventricular dilatation, third ventricle, and both lateral ventricles. Also, we have widened cerebellum fissures and extra-axial CSF spaces, so we have central and cortical brain involution changes. We have also diffuse ischemic changes in the white matter, small chronic ischemic changes. So in conclusion, we have left thalamic small hematoma, and left thalamic small hematoma is considered one of the characteristic locations for the hypertensive hemorrhage. So we have here 4 main characteristic locations for the hypertensive hemorrhage: basic ganglia, brainstem, cerebellar hemispheres, also the thalami. This is our third case today, trauma patient, and the most significant abnormalities is these areas: some petechial hemorrhage, located at the high parietal region, at the gray-white matter interface. We have also some petechial hemorrhage here and here. The first possibility in these cases, once we have trauma case and we have subcortical hyperdense foci, hemorrhagic foci, the first possibility is diffuse axonal injury. Diffuse axonal injury can be induced by shearing force. This one can be located at three main locations: the corpus callosum, secondary gray-white matter interface, and third location is the brainstem. So we have three main locations for the diffuse axonal injury: either corpus callosum, gray-white matter interface, and brainstem, mainly as a dorsal aspect of the brainstem. The second differential diagnosis for these areas may be cerebral contusion, maybe also hemorrhagic brain metastasis, as in case of melanoma metastasis, for example. Also, we have multiple cavernomas. All of these are our differential diagnosis for this case. But in our logic thinking, once we have trauma patient and once we have this large subgalley hematoma, so we have here great force, and this one can be manifested by this petechial hemorrhage at the subcortical region. Petechial hemorrhage can be easily detected by MRI study. Sometimes the petechial hemorrhage or diffuse axonal injury almost indistinct in the CT brain, and the most sensitive sequence in the MRI is the axial T2 gradient or SWI. Both of these sequences are very sensitive to detect microbleeds in the brain and to detect the diffuse axonal injury. And this one sometimes explain why the patient is comatose, why there is a discrepancy between the radiological finding of the CT brain and the clinical situation of the brain of the patient. This difference or this discrepancy can be explained by diffuse axonal injury, which is not visible in the CT brain and easily visible in the MRI study. But in this case, we can detect petechial hemorrhage very easily. It's another case and this patient is complaining of acute onset of disturbed conscious level. And really, the most significant abnormality is located at the left frontal region, this hyperdense area in the white matter. And this one, as you see here, it is not associated with effacement of the cortical side. So most likely chronic insult. Look for the ventricular system as well. The body of the left lateral ventricle is dilated as compared to the contralateral side. So we have here loss of white matter. So this area represents area of deformation with secondary negative mass effect. We also have here some small hypodense areas at the left basic ganglia region, also at the right thalamus, small hypodense areas of near-systemic density, most likely of chronic ischemic insult. But we don't have any more gross abnormalities. But as we said before in one of our previous videos, let us go or end by your checklist. If you go by your checklist, you will find something abnormal in the high parietal region. Look for this area and this area. We have here preserved cortical sulci, and we have here loss of the cortical sulci. So we have something abnormal. As we see here in the common plane, we have an extraaxial collection, and this collection shows concave inner border and doesn't cross the midline. So this is the collection, and this collection is hyperdense in relation to the cerebral parenchyma. So we have here acute subdural hematoma at the left high parietal region. As we discussed in many previous videos, we should measure the maximum thickness of the hematoma, and we should comment on its mass effect. I think it is slightly abutting the gyri of the left high parietal region. Otherwise, it doesn't cause significant mass effect. We have here the area of encephalomalacia with a negative mass effect, as we discussed in the axial plane. My last comment here, if we have a hematoma, hyperdense hematoma, we will diagnose it at acute subdural hematoma, but take care. Sometimes some patients are anemic, so don't expect that the hematoma is so hyperdense in the CT exam. Again, sometimes subdural hematoma isodense, not hyperdense, and at the same time it is acute subdural hematoma. Why? Because the patient is anemic. the hematocrit value is low. So don't expect that the hematoma in these cases, in this particular cases, anemic patient, to be hyperdense. Sometimes it appears isodense. So take care for this point. But again, the typical form of acute subdural hematoma or acute hematoma is hyperdense. Subacute is either isodense. Chronic form of subdural hematoma or extradural hematoma is hypodense. Okay, this is the last point here in this case. I hope you enjoy our lectures, and happy Ramadan for all of you. Thank you so much.